Okay, everybody, we're going to get started. Thank you for joining us today for our March early echo session. Bailey, if you want to switch to the next slide. Just so you all are aware, we are recording this session. We are hoping that you will be interactive and turn on your cameras and connect with us. Next slide. We are an interactive community, so we really are hoping to have some engagement and participation. That we will have a minute after the didactic presentation to ask Dr. Higbee some questions of his presentation, as well as then we're going to hear an amazing case presentation. If any of you are ever interested in doing a case narrative, please then connect with us at earlyecho@usu.edu. We'd love to hear any cases that you have. Next slide. As we are talking about people or we're talking about anything, please remember to protect individuals' privacy. So try not using don't use their first names or any identifiable information that we could connect back to that. If you're unsure, please reach out to one of our hub members. We all have an asterisk in front of our names, and we would be able to gladly answer any of your questions. Next slide. Please rename your profile picture. It helps us know who you are, as well as if you have not put the information in the chat, please put information in your chat, the contact and information. Next slide, Bailey. We all know probably how to raise our hands on Zoom now that this is our new normal, but here is a way to do that in case you are unaware of that. Next slide. Again, if you want to pre-register, we have some pretty amazing presentations for the next year. So you can reach out to Early Echo at USU to always pre-register or contact the link on our website. Next slide. We send out those certificates of attendance after the evaluation for the sessions have been completed by you. So after today's session, you will get another email with a survey. Please take a minute to complete that survey. It gives us some great guidance of how to recruit for new sessions, as well as to advocate for new monies to keep these sessions free and interactive. Next slide. Canvas is where we store all of our information. So the PowerPoint recording of the session, the case recommendations will all be on our Canvas site. If you have any questions about that, please reach out to Kurt Phillips at usu.edu. He would be able to help connect you with that. Next slide. Just another plug for those case studies. If you have a real life situation that you are struggling with or want some information from our colleagues about that, please take a minute and consider promoting a case. Next slide. REDCap is the survey. If it doesn't come to your inbox, please check your spam or junk mail. Once again, that's just a great way for us to, as a hub team, to continue to provide these sessions free. So take a minute and fill out that survey. Next slide. Next slide. So I'm thrilled to have Dr. Tom Higbee sharing information with us today. He is up here at Utah State University. He runs the ASSERT program and is just a wealth of knowledge and information. So I'm thrilled to have him present today, and I'm going to stop talking and turn that time over to Dr. Higbee to share with us.
Thanks, Janelle. It's great to have a chance to meet with you guys today. Give me just 1 second to get my screen shared and then to resize all of you guys so that I can see you as best as possible. We love the Zoom and the flexibility that it gives us. If they were asking me I would be happy to provide them with several suggestions about how it could be improved, but so far they haven't asked me. Thanks, Janelle, for that introduction, and it's great to have a chance to hang out with some early intervention folks. And thanks for letting me be with you, even though technically I dwell more in the kind of the preschool realm. I come from a long line of early interventionists. Well, my mom anyway, worked in the early intervention field for many, many years down in Southern Utah. And so I'm happy to be here with you to talk a little bit about autism and about strategies for supporting individuals on the autism spectrum. So yeah, please let me make my chat visible again. Feel free to raise your hand if you have questions, or to put questions in the chat. And Janelle, if you can help me monitor the chat, sometimes I'll just get going and talking and get excited and not pay attention. Please feel free to interrupt me and call me out if there is a question that I can address.
Perfect, absolutely.
So like Janelle said, I've been working in the field of autism spectrum disorders for about 25 years now, and I've been here at Utah State for 20, which is hard to believe. It makes me feel old. I do not call myself an autism expert, however. The only autism experts are people with autism. I have had the privilege of working with a lot of individuals on the autism spectrum and their families over the course of my career. And so I'll be drawing on those experiences as I talk with you guys today, but I would not pretend to know what it's like to actually have autism. Janelle mentioned the ASSERT program, and the ASSERT program is a early intensive behavioral intervention program here on the USU campus. You all have open invitations to come and visit whenever you would like. Right now we serve about close to 25 families here in the Cache Valley area, providing them with high quality research-based preschool services. And the mission of our program is to do three things. One is primary mission is to do that, help those families we can impact directly, that participate directly in our program. We also conduct research on developing evidence-based strategies to promote language, social behavior in individuals in the autism spectrum. And then we serve as a training site, both for USU students who all of our early childhood special education majors do a semester-long rotation through the program, and we host people from all around the world to come and train with us. And like I said, all of you are invited. Part of our mission is to provide training and support. And so don't hesitate to reach out if there's ever anything we can do to help you. If you ever find yourself in Logan or Northern Utah and would like to stop by, just shoot me an email and I'd be happy to set it up. We run 12 months of the year. So even during the summertime when things are a little bit less structured, you might have more time and want to come hang out and get a visual of what we do, please feel free to reach out to me. Now you guys, again, just a quick review, because I'm sure you guys are all familiar with autism amongst the range of things that you guys work with. But we know more about autism than we did, but certainly not a whole lot compared to some of the other developmental disabilities that we interact with. We know that autism spectrum disorder, which I'll talk about that word and that title in a minute, we know that it's a developmental disability in the sense that what that means is it's present from birth. It's not something that's acquired, and it's categorized by differences in the way the brain works. It affects the way individuals on the autism spectrum communicate, and it also affects the way they interact with and engage with the social world. And then up here is the standard IDEA definition of autism, which I'm sure you're familiar with. Essentially, and I'll talk about this more in just a minute. So when I talk about autism, I kind of talk about those three primary areas that it affects. It certainly affects communication, and it affects the ability and the way that individuals on the autism spectrum communicate. But it does so in different ways. And autism spectrum disorder is this broad umbrella term that describes a wide range of individuals. So wide, in my view, that's almost non-functional at this point, but I'll talk about that in the next slide. All the way from individuals who have virtually no functional communication skills at all, or no effective means to communicate their basic wants and needs, all the way up to individuals who converse like you and I do, but even their language might be a little bit different. It might have a tendency to be a little more concrete, a little more direct, a little more focused on their particular interests and less focused on sometimes the interests of other people. So this broad range, there's a saying within the autism world. Well, if you've met one person with autism, well, then you know one person with autism, because every individual is unique. I've worked with identical twins before who genetically were the same, raised in the same household, and autism manifested itself differently, and the way they learned and was different. And so everything has to be individualized. And the second main area that autism affects is social emotional functioning. And again, this runs the gamut from individuals who have absolutely no interest in the social world, all the way up to individuals who are super interested in the social world, but might lack a few core skills that allow them to interact and interface effectively with that social world, and everything in between. And then the third part of the kind of diagnostic criteria is that individuals also on the autism spectrum tend to have restricted patterns of interest, things that they're hyper into at the expense of all other things. Some individuals will have other kinds of behavior problems. Behavioral rigidity is also a common, not always present characteristic, but these are kids, especially when they're young, tend to be more resistant to change, resistant to modifications of routine. And those can be routines around what they eat, how they sleep, the way we drive to the preschool, all sorts of different things. And some individuals, because largely due to their communication challenges, develop severe forms of problem behavior that make them a danger to themselves and sometimes other people as they get physically larger. Now you see here on this slide, I've got arrows linking all of these characteristics because they're all interrelated, right? We know this. It's really hard to effectively interact with the social world if you don't have good communication skills, right? And by the same token, I can have all the words in the world, the largest vocabulary in the world, but if I don't understand the way social behavior works, it's going to be very difficult for me to effectively use that language to get my wants and needs met. And what happens in the absence of an understanding of the social world and absence of good communication skills, we have behavior problems because people will figure out ways to control their environment if they can't do so through functional communication, right? And it makes sense. You and I find ourselves in situations that we find uncomfortable, and we have developed ways to get out of those situations. Okay, we fake the text. We look at our watch, say, "Oh, look at the time." If imagine yourself being in a situation that's highly uncomfortable for you and having no means of escape, no socially appropriate means of communication to get out of that environment. Would you figure out a way to get out of that environment? Well, sure you would. And that's what a lot of our kiddos do if they don't have the communication skills to do so in a more socially acceptable way. That becomes sometimes aggression, sometimes meltdown tantrums, sometimes even self-injury to communicate basic wants and needs. So those are kind of the three parts of kind of the autism spectrum disorder triangle that I talk about, and they're all interrelated, just like the points of a triangle. And it affects people in different ways, but in order to get this particular diagnosis, all of these areas kind of have to be impacted. We'll talk a little bit more about that in a minute. So it used to be that we had kind of different categories within the autism. We had autistic disorder, we had pervasive developmental disorder, we had Asperger's syndrome. None of those words or categories exist anymore in our current diagnostic structure, which makes sense because what used to happen is highly trained clinicians that do the diagnosing, they could get really good reliability amongst people doing the diagnoses on does this kid fall on the autism spectrum or not. But when they tried to sort people into those three different categories, it all broke down. They couldn't get good reliability. And so on that level, the categories weren't super functional. And so they got rid of those categories and decided just to talk about this as one big thing. and then classify individuals according to the level of support that they require in order to effectively interface with society. And that made sense at the time. At the time, I thought it was a great move, you know, because it would let us identify the level of the individual more what the support needs were. It's had some side effects, though, that have really only come into view, I would say, in the last few years. And it's interesting, kind of from a sociological point of view. We now have individuals who are on one end of the autism spectrum where they have great communication skills. They're going to school, fully included, graduating college, holding down jobs, who have the same label as individuals with severe intellectual impairments who can't communicate, who need 24-hour care, and those are all called the same thing. And that has caused, you know, some problems. And maybe you've heard about some of this and things, people talking about this. And we have individuals who are on that end, the high skill end, who want to be the voice of all people with autism, including those who don't have any voice at all. And it's really interesting. And I put this terminology slide up just because it's related to this kind of the movement. You've heard of them, perhaps the neurodiversity movement, and individuals, and they call themselves autistic self-advocates, you know, and they're very active online and on social media and comment boards, and they have a lot to say, and which I think is awesome. It's difficult though when that one perspective is the only perspective that's presented, and parents, for example, who have children who have much more significant disabilities, their voices sometimes are being silenced or shouted down a little bit now, which infighting is not ever productive, I don't think. But I think it really comes back to that diagnostic change in terms, we used to have different categories that people could identify as, and now it's all one thing, when these people were really, really very, very different from one another. So it used to be we used all person first language, and that's how I was trained. That disability is a piece of this person, but it is not what defines them. Okay, and so we use terms like children with autism, and that's what flows off of my tongue, because I work again with little kids who are still developing whatever their identity is going to be. And so I don't presume to be able to speak for them. And so that's the language that I always use. And those individuals that are part of the neurodiversity movement, the autistic self-advocates, however, if you have a conversation with them and you poll that particular subgroup of the autism spectrum, they will almost universally say they prefer what's called identity first language. They say that autism is a defining characteristic of me. It affects my brain. It affects every aspect of my life. It's not a purse that I carry around with me. I'm not a person with autism carrying around my autism purse. I'm an autistic person, which also makes a lot of sense to me. And again, we have this big spectrum, and keeping everybody happy is proving to be kind of challenging. So I'll flip back and forth from these two terms. I'd be explicit about this. I'll probably use more the person first language, just because that's what I've been kind of come up with, and that's more comfortable for me in the age range I work with. I have no problem with using identity first language. If someone tells me that that's how they want to be called, I will 100% do it, and as we all should. And what I'm really kind of trying to train myself to do now is to default to kind of a generic middle ground term, and that is a person on the autism spectrum. And that seems to be a term that is palatable to most of the parties involved. Again, does language matter? Does how we talk about people matter? Oh, of course it does. Of course it does. So that's what I'm trying to train myself to do most of the time now, to minimize the number of people that I offend with my language, is just to refer to individuals on the autism spectrum. Whether that will work for you, I have no idea. I don't even know if it's working for me yet, but I imagine over the next few years, I will get feedback as we get back to presenting more, I'll get feedback. But as always, respect the wishes of the individual. They want to be called something, call them that. I think that's fantastic. So we know autism is diagnosed behaviorally, and that's part of the tricky part, right? There's no blood test, there's no genetic test, no brain scan that can detect autism. Autism essentially is a label that we have created to describe these particular patterns of learning and interfacing with society. Like we talked about, the three areas. We know that it has to do with brain development. There's evidence for its heritability, and there's some subset of cases that can be explained through genetic differences, but not all of them. We still can't explain the majority. And in reality, I hesitate to use the word expert, all scientists who study autism would tell you that in all probability, it's not a singular thing, a singular disorder. There are probably multiple reasons that lead people down this particular developmental path that we've given the label of autism to. And so we're still doing it, we're doing the research, we're trying to find it. I don't think there's much of a chance we'll ever find a single smoking gun, because I don't think it's a single thing. I think there's not an autism, there are autisms in all probability. But I let much smarter people than me do that kind of work. Now for you guys, as you're looking at the kiddos that you have a chance to interact with in the families, these are kind of the things we look for. And I am not a diagnostician. That's not what I do. So this is stuff that I've pulled straight off of the CDC website, and I'm sure you guys are familiar with it, or Learn the Signs Act early program that the CDC has promoted, which has been great over the past few years. They've done a much better job at getting pediatricians the information they need to do developmental screeners that can hopefully get these kids identified sooner, out to you guys sooner, so we can begin to provide the families with support. And really, equally important as providing support to the kiddos is providing support to the families and helping them learn about the systems with which they're going to be interacting over the next few to many years to provide support both for them and for their children. One of the kind of the clearest markers, if there's one clear marker, it has to do with joint attention. It's one of the things you can pick up on earliest for kids who don't engage, don't respond to bids from adults for joint attention, or don't make bids for joint attention. That's just that basic social referencing, and even you guys know, very small kids do this, where they find a toy, they pick a booger, and they look at the booger and show it to mom, and we're both looking at the thing together, and we're moving back and forth between faces and things, right? Infants, very young toddlers do that. That's something that seems to be missing in many individuals on the autism spectrum, even very early. And then again, go through the list of other things that kind of are red flags, which doesn't mean that a kid necessarily has autism, because as you guys know, human development is so varied, but it does mean that we might want to do some additional examination, because what the research has been very clear about it showing us is that the earlier we can identify, the earlier we can get these kiddos into supportive services, the better their ultimate outcome. You guys know, you guys are the front lines. All the work that we do in early intervention in preschool, we're really, we are the foot soldiers of special education. All the gains that we can produce, these kids are going to carry with them throughout their life and throughout the rest of their educational career. We should be paid a lot more than we are. I'm going to talk to somebody about that. Because we're the most important piece in this great machine.
I think we would all second that thought, Tom.
Yeah, it's so not fair. We do get to play with cute little kids. I guess that's some compensation. But you can't spend that at the bank, right? Other kind of markers on the social emotional side, the way kids on the autism spectrum play tends to be different from typically developing kids. And what's interesting is you look through these things, these are all things that typically developing kids do too, right? Do typically developing kids engage in repetitive motor movements? Oh, sure they do. That's how they explore. When their behavior comes in contact with the social world and social reinforcement, though, those behaviors tend to drop out because they learn more fun things to do. For whatever reason, kids on the spectrum tend to get kind of stuck at that developmental stage of self-stimulation. And because they don't connect to the social world, some of those interfering repetitive behaviors don't drop out like they do in typical kids. Do kids get upset by minor changes? Yes, lots of kids do. But it's about the persistence of these and the degree of these things happen and the collection of multiple checks through these boxes that start to make us be more concerned. Again, the language skills developing, and is there variability in the way language develops in typically developing kids? Oh, of course there is. But again, you're not saying words, and especially if we have a set of words that all of a sudden stops being used, that's a big red flag. To be able to, we want to get probably some more evaluation. And many kids on the spectrum also have these kind of comorbid other disorders. They tend to have, some will have seizures, some will have, the vast majority will have unusual eating and sleeping habits. That's almost could be put in as one of the diagnostic criteria. Some of them will have GI issues, constipation, diarrhea, those sorts of things. All these are things that, as you get more and more of these things that are checked on our boxes, it's like, you know what? I think we should probably get checked out. Now, why are we talking about autism? I mean, you guys, any of you who've been in the field for a while, you're like, have we seen more and more and more kids on the autism spectrum being diagnosed and sent to our programs? Yeah, I mean, I've been here, like I said, for 25 years, and we've gone from like 1 in 1,000 to the latest data, like 1 out of every 44 live births is going to fall on the autism spectrum. I mean, let that sink in for a minute. That's a pretty high number. Virtually every time we count it, the number goes up. Now, those are scary, and people will throw those graphs up to say, holy crap, we're facing this autism epidemic. And I don't know if that's true or not. If you talk to an epidemiologist, most would say we can account for a lot of that in 2 things. One, we're much more aware, and so we're picking up these kids better than we did before. And 2, the diagnostic criteria has in fact changed. It has. We have broadened what qualifies as the autism spectrum, especially for a lot of those individuals on the highly verbal end of the autism spectrum. They might not have gotten that diagnosis 10, 15 years ago. And some of those individuals on the kind of low verbal end of the spectrum, we might not have also diagnosed. They might not have been given just a standard diagnosis of a developmental delay or intellectual disability. So we're certainly better at diagnosing it now than we were. But to you and me, it doesn't really matter if these are all people that are new to the party, or if they were here all along, we just didn't know they're here, and we've got to be ready for them, and we've got to figure out good ways to support and help them. I can quickly summarize for you what we know about causes of autism. Not much. We know what doesn't cause it. It's not caused by vaccines. We know that, and the only reason we even talk about that is because of an unethical researcher named Andrew Wakefield in the United Kingdom, who didn't do bad science. He fabricated data to support a theory that he was espousing. And we're still talking about it, again, 25 years later, even though there was never any evidence for its veracity. These are other theories, too much TV, old dads, which too much TV is bad for anybody. I'm not gonna lie to you, it doesn't cause autism, though. Sadder was we used to blame, in the early days, in the 70s, they would blame mom and dad. They would say, it's your fault. You were a cold, unfeeling refrigerator parent. Let's be honest, they blame mom. Dad doesn't get blamed for much of anything. And because of that, the child went into their shell and became autistic. Terrible, terrible. That's in my lifetime that those kind of things were said. And it's never any evidence for that, and it's certainly not true. Like I said, there is, for some subset, clear genetic contributors, and for many others, we just don't know. And so scientists, like I said, the consensus now is there are multiple factors that kind of blend together that cause kids to go down this developmental pathway. Good news is we've got much better supports than we do, 30, 40 years ago. We've developed effective intervention strategies that can help maximize the independence of individuals on the autism spectrum. It used to be, back in those early days, they would just tell parents, your kid can't learn, send him off to the state institution where he'll live his life, and it's your fault for doing that to him. It still makes me angry just to think about that. We now know that it's not that kids with autism can't learn, it's just that they might learn in different ways. And so we might have to construct the learning environment differently than we do for a typical developing child. As you guys know, most of what typical developing kids learn, especially in the early years, they learn naturally. I mean, it's naturally because no one's there structuring it for them. But what it is they're exploring their world, getting feedback from their environment, either directly or socially from parents or other caregivers. And that just periodic feedback is enough to keep that developmental train chugging along. It's amazing. I worked with kids on the spectrum before I had my own kids. And when my oldest daughter was in that beautiful 18 to 24-month-old period and her language started to emerge, it just seemed so magical to me. I'd come home from work and she's got all these words that she didn't have when I left. And I'm like, who taught you that? I've been working with this kid for 6 months to get 5 words, and it's not, it does seem magical. For whatever reason, because individuals on the autism spectrum, many of them don't tend to be outwardly focused. They're not exploring their environment. They're not learning from their experiences. They're not attending to the social cues and feedback from their environment. The skills don't emerge naturally. And so what we have found we have to do is we have to structure that time for them and create opportunities for them to explicitly practice those skills that they will need. And that's the reason why it's so important to intervene early, right? I mean, you guys know, the difference between the number of things a typical 3-year-old does and a 5-year-old does is very great. And so if we can get the kid identified by age 3 and start early intervention, intensive programming, that developmental gap is still relatively small. We've got a good chance at catching them up to where they need to be. But you don't diagnose the kid until 6, 7, 8, and they're still flatlining developmentally. That gap gets to be so large that there's just not enough time, not enough hours in a day to rebuild all those skills. And plus the kid also has more time practicing these social avoidance behaviors that continue to isolate her and keep her from interacting with the social world. And what happens to things we practice? We get good at them. And it gets harder and harder to break through those behavior patterns the older the kids get. And so, which doesn't mean that the same intervention techniques don't work for older kids. They totally do, and we can adapt them. But the kids that make the dramatic gains that go from not talking at age 3 to I'm fully included when I go to kindergarten, those are all kids that we start with early. I've not heard of a case where we've got an 8-year-old person who's completely nonverbal. We do 2 years of intensive intervention, and then all of a sudden they're ready to go to fully included middle school. It just doesn't work that way. So earlier the better. That's what I mean. You guys are the front lines, and you guys are the gatekeepers at getting people in. That's why you're so important. The most effective strategies we've found so far are those that are based upon principles of applied behavior analysis. Or you've heard the term ABA. It's used as kind of a noun when it's actually initially stands for applied behavior analysis, or the applied branch of the science of learning and human behavior. And we've learned that more intense is in general better than less intense in terms of because that's just more of the student's day that'll be structured. Now, not everybody needs 30 hours a week, 40 hours a week of instruction. That's crazy. But some kids do. Some kids do need that level of intensity. So we can structure and give them opportunities to practice the skills they need. So I wanted to kind of outline for you guys what that kind of ABA or behavioral approach looks like to supporting kids on the autism spectrum, and contrast it with kind of our traditional way of looking at disability, which I have in this top graphic here, the traditional view or kind of the medical model. And that is we've got this underlying condition called here in this case the autism that causes all these symptoms, communication deficits, social deficits, play deficits, and some challenging behavior that goes along with it. And the idea is that if we would just fix this autism, find this cure for autism, then we'd expect all those behavioral symptoms to go away. The downside to trying to apply this logic model to something like autism is, one, we have absolutely no idea what the autism is. We're certainly nowhere close to having any biomedical interventions that can directly treat it. And we get caught in this feedback loop of, so why is the kid not talking, playing, and not social? Well, because they have autism. Well, how do you know they have autism? Well, because they don't talk, they don't play, and they're not very social. And we just spin in circles, and it doesn't take us anyplace. And so with our approach from the behavioral perspective, we take a skills building approach. We're like, okay, so you have communication challenges. Let's work on that. Let's teach you more effective ways to functionally communicate. You don't understand the social world or interface with it very well. Let's target that. Let's build some skills that will allow you to effectively interact with the social world. Same thing with play. Super important, right? Play is young child's work. That's where we want to intervene. That's how they learn those social norms. We have interventions. That's actually one of my research lab's main focus points, is developing play interventions. teaching kids how to play in an effort to engage more appropriately with the social world. And then we even have evidence-based strategies to target those challenging behaviors. And so we target those directly. It's not we don't worry about the autism, but we tackle these behaviors directly, because for now, that's all we've got a chance. That's all we've got. I think it would be great if one day they identify the specific cause of autism and find out the biomedical solution to it. I've got plenty of other things I could do with my time. I don't think it's happening anytime soon. Not to be pessimistic, but I don't think it's happening anytime soon. So just to tell you a little bit more about this behavioral approach, and it looks like about 5 minutes I got left. What we know is that the environmental events that surround behavior influence how likely it is to be repeated. So this is kind of like the core philosophy of our approach, and that's that all behavior happens for a reason. And the reason why behavior happens is because of that impact that it has on the environment and the feedback the organism gets from the environment. We call the core principle is reinforcement. We do the things we do largely because it produces the consequences that we want. The reason why I present to groups of people is because I get the periodic head nods and smiles and like, yeah, I mean, professors love social attention, and so any kind of social attention is rewarding to me. And we tend to behave in ways that minimize the negative feedback from our environment. We don't go around touching hot stoves because we learn from that one experience, or even from watching somebody else do it, that, oh, that hurts when I do that, and so I'm not going to do that again. That capacity to learn from our environment is what keeps us alive as a species and able to procreate and pass along our genes to other people. But I don't know if you noticed what I did there. It was a little philosophical trick, but I think it's an important and a cool one. And it's the primary reason why I'm a behavior analyst and not something else. And that is, I took the causes of behavior and took them out of the person and put them in the environment. Okay, again, philosophical, sure. The cool part about doing that, though, is that if the causes of behavior are really in the environment and they're not tied to this label or not tied to this kid being a bad kid, I can change the environment, right? And if by changing the environment, I can change the student's behavior and learning patterns, that's pretty awesome, because that means that everybody learns, everybody can change, even kids who have had a rough developmental hand that have been dealt to them. They can learn and they can make progress if I carefully construct the environment in a way to support their learning, to maximize the positive reinforcement for the good pro-social behaviors and minimize the reinforcement for the negative behaviors that are going to ultimately cause problems for them. I can help them learn to behave in ways that'll be in their long-term best interest. Which is, for me, an inherently optimistic view. I believe that anybody can change. Even people like me, I can change. See, I told you I was trying to change my language and the way I talk about things because I've gotten feedback from my environment. And even individuals with severe disabilities can change. And as I work with the parents, and that's a large part of what we do too, is we're not just supporting a child, we got to support the family too. And I tell parents, I say things that are somewhat controversial to catch their attention, and I'll say it here now. I say, having autism is not an excuse for behaving badly. Now, what I don't mean to say by that is I 100% understand that the autism affects the way this kid behaves. It affects the way she sees the world, and it affects the way those consequences affect her. But what I say by that is this: that doesn't mean that she can't learn to behave better than she is right now. Okay? And what I hate to see is people setting low expectations for their kids just because they have a particular label. If we set low expectations for kids, they're certainly going to meet those low expectations. If we set high expectations for our kids, they may not meet them, but they've certainly got a better chance than if we never ask them or expect them to do anything. And that happens, and it happens in special ed too. We'll say, oh yeah, well, little Johnny's got autism. Of course he's going to be lining up his toys. Let's just let him do his thing. I'm like, no. If that's going to be something that interferes with his social development, we got to get in there and teach little Johnny a better way to play with toys that will let him in the future interact with his peers, build social connections, one day hold down a job, live independently. Because every 3-year-old I see, I think of them, what are they like when they're 22? And the work that we do when they're little has a big impact on that 22-year-old. Man, and if I can get a kid to the point where they can tell me to piss off and I don't want to do it anymore, I feel like I've done my job. That's fantastic. So yeah, everybody can change. Everybody can change. And that's why we look at things from a behavioral perspective. It's like, what are they getting out of this? And can I figure out a way for them to get that thing in a more appropriate way by skill building? Everything's individualized, everything's customized to the needs of the child and the family. And there's no, cookie cutter approach or anything like that, because every kid is unique. The first task we do when we get kids is like, get to know them, figure out what do you know, what don't you know, and then how do we teach you those things you don't know that we think are going to be important for you later on. That's kind of a good stopping point, Janelle.
Yeah, I'm sure that we're all saying that we could listen to you for just a way longer than we have time in this echo session. So I'm sure we'll be reaching back out to you to present again. I'm going
well,
to
you know that I love to talk, so I'm always going to say yes. I mean, the only person that might like listen to my voice more than you would be me. So anytime I'm happy to chat with you.
Well, great. I'm going to open it up to questions for about the next 5 minutes. So feel free to put them in the chat or just unmute yourself and rack his brain about things. Because I loved that approach of just talking about changing the behaviors. I mean, I think that here in early intervention in our Up to 3 program, that is certainly what I tell families and work with them on that too. So there's one in the question that says, what are your views on the THC CBC therapy? CBD, sorry.
Yeah, great question, Pat. And I haven't reviewed a ton of research on that yet. Given the fairly recent legalization of those sorts of approaches, we don't have tons and tons of data on that. Just like we've got data on using other types of medications. Mostly what medications are used for, and I imagine it would be the same thing with the CBD type stuff, are to treat kind of comorbid issues with older kids, like the anxiety issues that'll sometimes be there. And if a little bit of anxiety medication can help knock that down to a point where we can do some more skill building to help relieve the causes of that anxiety, I've seen that used effectively. I don't know specifically about THC, CBD. Sometimes feeling better puts you in a position where, intervention or active treatment can work a little bit better. I don't know how, especially, I work mostly with little kids like you guys do. Go ahead, Pat.
Okay, got to unmute here. Well, I just have been involved with kiddos with seizure disorders and management of seizure disorders where no other medication can get them out of that cycle. So it is a brain changer. And of course, 60 Minutes, I watched a program about it changing the self-abusive behaviors on children who were, beating their heads against walls and biting. And so to me, what is the research?
Yeah, it's really just getting started. I couldn't point to like a concrete studies, but it's certainly worth exploring, I would think. And one of the theories about why some of that self-injury happens, especially the head-related self-injury, right, head hitting and head banging, is that it's an attempt to kind of it's a response to some type of internal pain, and that's a way to even release the body's endogenous morphine or endorphins. That there's not tons of research on that, just because that research is really hard to do with participants who often can't tell you how they're feeling. In many cases, they're telling you with the behavior. So I don't know, Pat, but I think that's something that definitely warrants investigation.
Great. And then the other question is do you have suggestions to how to help guide parents that have some denial about their child's diagnosis and related behaviors to bring them to ABA?
Yeah, that's a great question, Lori, and it's tricky, especially with families that you might not have a lot of rapport with or a lot of information. In today's day and age, the argument that I always use is that What we know and what the research shows consistently is the earlier we start providing supports, the better the ultimate outcome. And none of the supports we would provide for an individual on the autism spectrum would have any damaging effect whatsoever if it turns out that this kid is just a little bit slow in development. In fact, we would know that pretty quickly because they would respond so quickly to the intervention that they would just fly and take off. And so that's the kind of rationale that I use, even if parents aren't all the way there yet, is just like, hey, this is an intervention that's going to help regardless of what the issue is. And so what do we really have to lose? It's not risky. You have to respect though families. For families, this is hard, and it's getting easier now just because more information, unfortunately, more information, not all of it is good, is available. One thing that I've done in the past too is connecting them with other parents who are a little bit further along in the journey, and that can be helpful because when we talk about things as professionals, sometimes that can be viewed as self-serving. We're trying to draw them about business and things like that, and so helping them get connected to parent groups. And so that's kind of my general approach.
Yeah, that's a great one. And I love that. And I'm also, you mentioned the CDC's Learn the Science Act Early materials. That's a great connection as well. Each state has an Act Early ambassador. I happen to be the Act Early ambassador for Utah. So if anybody would also like some information and some resources on that, feel free to reach out. There's one more question I'm going to let us take, and then we're at time. So what are your thoughts on toddlers that improve a lot in EI, enough that parents think there is no longer an issue?
That's tricky because one level, like, yay, lots of improvement. But on another level, we also know that as you transition in each new environment and the demands go up, you're likely to see, those challenges emerge again. What I try and do is like, it's much easier to continue services than it is to go through the whole qualification process again to get into it. I'd say, I would suggest that you continue on. And if it ends up in 6 months that these kind of services are no longer needed, fantastic, fade back. But, it's so hard to get in the door. I always want to stay in there unless we're really sure that we don't need it. And help also them understand that the range of services available at preschool can be very varied, all the way from a fully inclusive, well, depending on where you live, right? All the way from a fully inclusive environment to a more specialized type of program. And then before I say goodbye, and I promise, I'm going to respond to the previous question, and they're just really fast. Angela, the short answer is ABA is a very broad set of strategies. And so if you're saying, can ABA help everybody? I think there's a version that could probably has the best chance of helping the vast majority of kids on the spectrum. Are there some individuals who don't need the intense version? Absolutely. Are there some individuals who do need the intense version? Yes. And there should be a highly qualified ABA provider should be able to customize the specific interventions directly to the needs of the child. But there are some kids who don't, who can, with a high quality, fully inclusive program would do just fine. And then for them, yay, let's get them in that setting. But again, the ABA is not one single thing, it's an approach. It's a skills-based and child-centered approach. And so as long as it's customized properly, it's just a ticket for the vast majority of kids on the spectrum. Well, I don't want to be rude to the next presenter. So thank you. I will say goodbye and I look forward to seeing you guys at some future date. And like I said, if you want to come visit, just let me know. I'd be happy to set it up.
Dr. Higby, thank you so much for your time and your expertise in this topic. If you are more than welcome to stay on for our case presentation, but I know you are a busy man with the dean of the department as well as running a cert. So
I would love to. I'm headed off to a lab staff meeting, so I'll leave you guys to it. See ya.
Okay, thank you. We have a wonderful case presentation today by Shauna Packer. I've lost you amongst the midst of my things, so say hello so you come up on my screen.
Hi.
Okay, so I'm gonna let you take it away for your presentation. Bailey will pull up your slides and we will go through those.
Hey, great, thank you. So I apologize if I'm a little bit all over the place with this. We've had new information since the slides were made. And I was working with Kate, the occupational therapist, in making them. So if it's a little clunky, I apologize. But my name's Shauna Packer. I'm a child development specialist with DDI Vantage. Bailey, you can go to the next slide.
And Shauna, I wanted to say, I also saw Kate on here. I know she was not going to join, but I thought I saw her join earlier, just so you know that.
Oh, great. Kate, pitch in anytime. Okay, so the background on this kiddo, she's a 25-month-old girl. Basically, other than a mild delay in gross motor, she has severe delays in every developmental area. I started seeing her last August, and then we recently added OT services maybe a month or two ago. She is now on the wait list to be evaluated for autism. A little bit of family culture. She lives with her mom and her dad and her two older brothers. I think her oldest brother is about 13, and she has a 5-year-old brother that, after visiting a few times, I realized is not speaking at all, completely nonverbal. So we talked about autism concerns. He's now scheduled or waiting for an evaluation as well. So this girl's mom appears to have some sort of cognitive delay, maybe also a motor delay. She has some trouble answering questions when we ask her in the appointments. She walks with a limp, and she holds her hand close to her body. She also has a strabismus, so her eyes are crossed. And in trying to kind of feel out if there could be any family delays or a family history of developmental issues, the mom said, no, there weren't any. But we were actually contacted by Early Head Start, who has started seeing the family, who said that the father was at an appointment and let them know that he has an extra chromosome. So that could potentially be an issue there too. So a lot of different dynamics that we're working with and trying to problem solve, and just kind of getting pieces here and there as they come. They live in a basement apartment. They have limited access to resources. I don't believe they have a car. And then another issue, it seems that no matter what time of day we come, the mom and the kids are usually asleep on the couch. So we don't have a super clear idea of what their sleep schedule is, what their routines are, but it seems that they're on the couch most of the time. Okay, next slide, please. Primary areas of concern. The biggest one is social and communication. She's not using any words functionally. She'll say mama and dada, but not in reference to her parents. They're just kind of sounds that she makes. She doesn't make a lot of gestures as far as indicating what she wants. If she wants something, she'll climb on a table and get it, or just kind of cry or try to take care of her own needs. Not a lot of eye contact going on. A lot of these things, like with many of my kids, parent report is very different from what I see. So her parents say that there's a lot of eye contact, but I haven't really ever witnessed that. Not a lot of imitation. The way that she plays is very just kind of repetitive movement, walking back and forth, moving beads up and down a wire. The one that made me realize there may be some real sensory issues there. We went for a walk, and she was more interested in scraping her fingernails on the sidewalk than moving forward. So it took us, probably 10 minutes to go maybe 20 feet. Again, we talked, she appears very lethargic. She can walk, she can sit up, but generally when we're there, if she's not asleep, she's like kind of folded into the couch. Her face just seems very drawn and tired. She was referred by her pediatrician. I know her parents want her to talk, but they don't seem too concerned of any additional delays, or that this may be more than just, she's delayed in talking. Okay, next slide, please. Let's see, goals and barriers. So the language goals, we have receptive goals about retrieving and pointing to familiar objects, following simple commands, looking when her name is called. One of the difficult things in this situation is figuring out how far back to dial it, because there's just no interaction. So we're coming back to very, very basic skills that we're working on. Expressive, we would love if she would imitate gestures in a game or a song and increase her functional use of sounds and words, maybe even request some needs that she has. The most engagement that we're aware of is she likes to run back and forth with a ball with her brother. We've never seen it because her brother is almost always asleep on the couch when we come. Let's see, gross motor and sensory, implementing sensory social routines to build engagement and imitation, running and jumping to progress with gross motor skills. Gross motor was actually one of the biggest concerns when we came because she wasn't running and jumping. Right now it's the least concerning delay. We've also made a family goal of getting outside daily. I think they spend a lot of time inside. So barriers, parent follow through and engagement in conjunction with a cognitive and mental health concern. So it's really hard to communicate with the parents about what exactly is going on, understanding where exactly their daughter is at, and then helping them understand the strategies that we're trying to implement to help her improve. And then difficulty finding activities that are engaging for the child. And we'll talk about this in the next slide, but it kind of every strategy just falls flat. Okay, next slide. Thank you. So things we've done, we connected with Early Head Start. They've started the process. I don't know if they've actually had visits, but they're communicating with them. Really grateful for that, because that's how we found out that that her dad had an extra chromosome, and now we can start problem solving that a little bit. We've recommended the parents bringing up specific concerns with the pediatrician to get appropriate referrals. That's how we got an autism referral going. I actually just reached out to her pediatrician yesterday to see if there are any diagnoses there that they are aware of, that we are not, or if we're working with this child's mom and her father and his family and the doctor to try and figure out what the extra chromosome is, so we know if there's a type of syndrome that we should be looking for with her, or if the pediatrician has tested for that. When I looked in BTOTS, the doctor had noted that there was a concern that there might be an extra chromosome, but no indication that they have followed up on that. Let's see. And then we've tried to set them up with community resources like the library. They didn't have any books in the home, really. We also set them up with our Sub for Santa program, and they were able to get some good developmental toys and also some books through that. Okay, next slide. So the questions that we have, and they're a little bit complex, but the first question is, how do we increase the likelihood that parents will implement strategies in between appointments? More specifically, especially when parents have complicated circumstances, like a cognitive delay, mental health issues, no time, lack of resources or skill, lack of buy-in, etc. And I think the next question mentions this as well, but sometimes there are cultural and language barriers as well that I deal with some of my families, where for some reason there's a breakdown in communication with the parents, and how can we help them feel motivated to find ways to implement those strategies in their families, and how can we best help the child if that's just not something that the parents can do. Second question is kind of related. How do we help parents with some kind of barrier, like we discussed, understand where their particular child is at? So another issue I've had is the parents just really don't understand that there is as significant of a delay as there is, and that makes it hard for them to know how to move forward with that or to be motivated to move forward with that. And then the third question is, how can we best use our time during an appointment when the delays are serious enough that strategies don't get any traction? For example, nothing holds their attention, they have no desire or interest to engage, or parents are not active participants. So a lot of times, if I try strategy after strategy after strategy and it just doesn't get any traction, I'll turn my attention towards the parent of like, okay, let's do some coaching. Let's talk about things that you can implement. Let's talk about how your child is doing. But in a complicated situation like this, the parents seem to get stressed out when we talk and ask questions and communicate. So I just feel like my hands are kind of tied as like, okay, strategies with the kid aren't working. Talking to the parent isn't working. How do I make this a functional appointment for them? So that's my case study.
Awesome. Thank you, Shauna. So we're going to go ahead and get in breakout rooms now. Janelle had to hop off, so I'm kind of taking over for the rest of the meeting. But I'm going to put everyone in breakout rooms. So if you could discuss those hub members, there's one of you in each. And if you could just make sure someone takes notes, that way we can send it to Shauna and put it in on the Canvas page. We'll go ahead and do that. And we'll come back around 1:20. So everyone has like 15 minutes. Everyone that's still here, if you should see that there's an invitation to join a room. So if you can do that, go ahead and do that for me. Okay, we're just going to give everyone a couple more seconds to get back on. I hope everyone had a great breakout session, that you had some good discussions. I'm just checking. I think all our groups are back. So we'll go ahead and just quickly share. We'll just go through each group. And if you just want to share maybe one or two things that you guys talked about, any suggestions you have. And then again, if you could just, whoever took notes, if you could just email that to either Janelle or I think the email's earlyecho@usu.edu. So yeah, so let's start with Barb. You're the first one on my list.
And actually, Shauna was in our group, and I don't know, Shauna, if you want to share the two you like the best or something.
Oh, I don't know if I could pick two. One, we talked about a lot of things. We talked about potentially seeing the family more often for less time, because it's really hard to fill that big slot with when the activities don't gain traction. One thing that we talked about was, if there is a delay with the parent, making things really concrete. So having a paper that you can hand them, or instead of on the spot, just asking her questions of what things are like, maybe have something that she can fill out through the week, or have her write down on an index card the one thing they're going to work on that next week. So there were like 6 other suggestions, but those were 2 of them.
Those are great. Okay, Heather, your group.
Hey, yeah, we talked about a lot of things too, so I'll just kind of narrow it down. The first thing, all of us noticed that the child, is again tired. Everyone's tired. So kind of going back to basics, what are sleep habits like? What about elimination, nutrition, right? Some of those basics. If we remembered years ago at a training, the Utah Parent Center, they talked about, again, you've got to get health. You've got to make certain that the child is healthy. And if there's an underlying infection, all of that is going to impact it. We also talked a little bit about making certain that we're having conversations with the parent, understanding what it is that the parent enjoys doing with their child. So they might be sleeping quite a bit, but they're not sleeping 24/7. So when they are engaged and when they are, interacting with one another, what do they enjoy doing? And that might help us in coming up with suggestions if parents are having a hard time thinking about what they want to do in between visits. That might help us come up with a plan that they're going to buy into. We also talked about plain language, making certain that not only is our written communication understandable, but our oral communication. We tend to use written communication at a more advanced level than our oral, but still, we don't really know what disability or potential cognitive delay this parent has. So we need to make certain that we're communicating in a language, plain language, where she can understand.
Awesome, thank you. Shelby, and your group, whoever's your spokesperson.
Yes. So I think really the biggest, theme that our group discussed was really creating that relationship, making that relationship stronger between you and the parents to kind of, support their possible mental health in order to get them to even have that ability to want to make a change, or just, mostly about addressing those mental health concerns, creating a better relationship with the family so that they look forward to seeing you and then going from there.
Thank you. Pat, you're next on my list. Oh, you're on mute, Pat. Sorry.
Sorry. Nobody heard that either. So the first one was to implement a reward system so that the parents could visually see that the task has been accomplished, and or the child visually see that the task has been provided. And unfortunately, I always go back to my medical, oh my gosh, somebody suggested they live in the basement. Is there a radon poisoning going on? Is there some kind of environmental issue going on that's creating this overwhelming tiredness? I say, what's their diet like? Is there blood work needed? So these are hard, and you have to pick away. You have to pick away and see. So those are the 2.
Awesome. Okay, thank you. Kirsten.
That would be me.
Okay.
So funny thing, or not so funny, is that I actually was the special educator for the oldest child, the 12-year-old.
Oh.
So Shauna, we need to talk because I know them really well. So a couple of things that we talked as a group, but that I can tell you all is that they're both fairly developmentally delayed, cognitively delayed. Dad more than mom. Mom does need pretty significant processing time and wait time when you talk to her. But they can be fairly organized when you give them a minute. But looking at how they, if they're visual learners, like you all have kind of said, if they're visual learners or how they learn best. So if you give them something that's already written down or how that works is a great idea. But the thing I did learn the simpler I talk to them, very straight, very black and white, you will not hurt their feelings. It is the best way to talk to them. So just put it out there. And they get it. So, but back to basics is going to be the biggest part. Getting them a better sleep routine, and EHS is going to help too. So working with EHS and you guys really going back to basics and starting that routine and just working with kids and getting them a little more sunlight, a little more daylight, and really getting them on a routine is going to probably be the best. And then start with the developmental milestones with getting everything else. So other things come first.
Awesome. Thank you, Megan. And what a small world.
Well, with DDI, so not.
Oh, so not actually a small world, but
A lot of kids.
Okay, Rebecca. I don't know if you were able to get on or someone else took notes for the last group.
Okay, I took notes for our group. We had a lot of overlapping suggestions, especially with the nutrition and then, or at least checking on nutrition and making sure that the family's basic needs were being met either through early Head Start or some sort of service coordinator. Like, is there something else that's just weighing heavier on their minds or that are bigger priorities at this point? And trying to address those so that they can participate a little bit more. Other overlapping things were just trying to get a little bit of parent input on the goals if it hadn't been already. We weren't really sure how those goals and objectives were constructed, but you know, maybe saying like what would be most helpful or most beneficial for your child to be doing to change your, I don't know, to incorporate in your activities, but really just trying to see what is at the top of their list, because if they're not concerned about whatever developmental milestone, we were worried that there wouldn't be the buy-in there. Trying to think of the others. Other things were just like where they do have an older child and it sounds like he's been through similar systems or programs, asking what strategies worked for them or what they may have learned previously, and maybe some of that recall to help build parent capacity on what they already know. Building parent confidence. I guess I'm over 2 here, sorry. I can stop talking.
That's okay. No, that's awesome. Well, thank you. Those are all great ideas that everyone had, and I know there was a lot more that you guys talked about, so make sure you send us those notes. That way we can put it on Canvas, but also that way we can send it to you, Shauna, so that you have all these great ideas and resources. And once again, thank you guys so much for coming to this session, and we appreciate all the questions and interaction that we had in the community that we're building, and we're grateful for each one of you. And just a reminder to look out for that survey that's going to come so you can get, whatever the credit is, I can't remember what it is, but you'll get some sort of credit, which is exciting. And that way we can continue to make these sessions better and make it more worth your time. And we want to make sure it's what you need for the kids. So do those surveys, and then we will see you next month on April 6th, which is exciting. Oh, my calendar just fell down, but we'll see you on April 6th for our next session. So thanks and have a great day.